common causes of pain in the forefoot. These will be divided into pathologies of the metatarsophalangeal joints, the intermetatarsal spaces, the sesamoids, the interphalangeal joints, and the toenails. We're now going to look at assessment of the painful forefoot. Patients may find it harder to localise the source of their symptoms either to the dorsal aspect of the foot or the plantar aspect of the foot when dealing with the forefoot. And this is primarily because the foot is not as deep in this part as it is in the midfoot.
Do you need me to turn up?
Again, we still ask the patient to try and localise their signs and symptoms. What is often very helpful if they point to parts of this, the symptoms which may be related to particular joints or areas of joints, so more towards the little toe joint, the big toe joint, or more in the middle. When considering the forefoot, we're really talking about from the mid-shaft of the metatarsals down to the tips of the toes. Some of the common features or common conditions which may occur within the ball of the foot would be arthritic change, particularly of the first metatarsophalangeal joint, but also of the lesser metatarsophalangeal joints and the interphalangeal joints. Irritation and inflammation of the joint capsule, so capsulitis or synovitis inside of the joint. A Morton's neuroma, either between the third and fourth toes or the second and third toes. A stress fracture of the metatarsal, which usually occurs at the neck, most commonly in the second, but can occur to any of the metatarsals. And sesamoiditis, which occurs on the plantar side of the first M2PJ around the sesamoids. To start with the dorsal examination, it's important to again assess the metatarsal parabola to see if one metatarsal is longer than the other, and this may be the location of the symptoms due to increased stress. It's also important to, in addition to the length of the metatarsal, to try and gauge the sagittal position of the metatarsal as well. And the easiest way to do that is to firmly palpate the joints in turn to see whether or not one joint feels more prominent plantally than the other joints. The first metatarsophalangeal joint nearly always feels more prominent plantally, primarily because of the position of the sesamoid bones. If somebody does experience a stress fracture, then localised tenderness, not of the joint itself, but of the shaft, usually at the neck, firm palpation in this area will often induce symptoms. You can also feel a thickening of the bone if the symptoms have been present for a 2 to 4 week period, which is the bone callus, which is forming as part of the bone healing process. When assessing for inflammatory change within the joint, it's important to compress the joint in order to try and induce the symptoms. The best way of doing this is to firmly hold the proximal phalanx and to hold the metatarsal neck and to then push the proximal phalanx into the joint, into the head of the metatarsal, and to then rotate it. This should induce symptoms if the patient has any synovitis or if they have arthritic change within the joint, and each joint is then assessed in turn. Again, holding the proximal phalanx, holding the metatarsal head, pushing it, and then rotating the toe in that position. Give it a second, and then finally the first. Capsulitis is often associated with pain and tenderness of the whole joint capsule. To try and reproduce the symptoms here, firm palpation both on the dorsal aspect and the plantar aspect of the joint, and again squeezing, and you can see how the tissues blanch as I let go. So firm palpation of the joint will often induce pain, again working your way across, like so, and again to the first. A common problem for lesser toes is something termed a crossover toe, and this is when the toe starts to deviate in the transverse plane, often in the sagittal plane as well. The commonest toe that this tends to affect is the second toe, which may then sit up and across the big toe like that. In subtle deformity, it's possible to discern laxity of the joint capsule. The way to assess this is again to firmly hold the metatarsal head, to hold the second toe, like so, to distract the joint and to then move the proximal phalanx on the metatarsal head. In significant laxity, you can actually move the bone on top of the metatarsal head, like so. One of the commonest differential diagnoses for pain in and around this area, in addition to capsulitis or synovitis of the metatarsophalangeal joint, is the presence of an intermetatarsal neuroma. The two areas where this may occur is most commonly in the third intermetatarsal space, less commonly in the second intermetatarsal space. The rough average is probably 3 times here to 1 there. Neuroma assessment is quite straightforward, but you need to be quite exact with the location of pressure. There are several tests which have been used to try and identify a Morton's neuroma clinically. The first test is to squeeze the forefoot. What we do in this situation is to firm pressure just on the 5th metatarsal head and also the 1st metatarsal head. You squeeze the toes together like so. Sometimes you will actually feel and hear a click when you do this, which is the neuroma popping out of the intermetatarsal space, moving plantally. It's important to try and reproduce the patient's symptoms, and in order to do this you require firm palpation in the respective intermetatarsal spaces. I would always suggest that you do this first of all in a space where you know there's not going to be a neuroma, so the patient has an experience of how much pressure you're going to apply. So, starting on the 4th intermetatarsal space, what we're going to do is, keeping the metatarsals squeezed together, we then push firmly with the thumb, actually causing splaying of the 2 toes. We start with the 4th space, also go to the 1st space, and we then do the 2 respective spaces. So firstly the 2nd space, again you can see how the toes move up and also splay apart. And the reason for this is that we're squashing the soft tissues against the metatarsal heads. And if there is a neuroma present, this will induce symptoms. And it tends to be far more reliable than the Mulder's click. The next test, which is also useful to try and diagnose a Morton's neuroma, is to splay the 2 respective toes like that with one hand, and then with your thumb and index finger of the other hand to squeeze the soft tissues between. The reason why we splay the bones is to ensure that we're not squashing the bone, but we're squashing the soft tissues. So it's like that. And again, you can see the blanching of the tissues as we've done the test. Again, with 3 and 4, like so. If that reproduces the symptoms, that's very diagnostic for Morton's neuroma. Moving on to assessment of the first metatarsophalangeal joint, we've already discussed the range of movement, restriction of which would be associated with hallux rigidus. The other common source of symptoms underneath the first metatarsophalangeal joints relates to the sesamoids. The sesamoids can usually be palpated by, first of all, dorsiflexing the toe, running your finger down the metatarsal phalangeal joint just behind the first metatarsal head, and as you plantarflex and dorsiflex the toe, you can often actually feel the sesamoid bones moving. Firm palpation here of the tibial sesamoid in somebody who has sesamoiditis or fracture of the sesamoid would induce symptoms, and then moving to the lateral or fibular sesamoid again to see if this reproduces symptoms. Another source of potential pathology in this area is a bursa sitting underneath the first metatarsal head. If that's present, you're likely to notice a discrete soft tissue swelling in this area, a spongy feel when you compress that, particularly in comparison to the other metatarsophalangeal joints. Bursae can also occur between the metatarsal heads, and the area where they most commonly occur is between metatarsal heads 2 and 3, with inflammation of this bursa often causing splaying of the 2 toes, the so-called Jacob's daylight sign or the Winston Churchill sign. With time, this tends to cause weakening of the joint capsule and soft tissue adaptation around the metatarsophalangeal joint, so even though the bursitis may become less inflamed, the toes stay in a splayed position. The inflammation of the bursa usually puts pressure on the nerve, and as a result of that, the patient will have neuroma symptoms as well. So if the patient naturally has toes which are splayed apart like so, it's nearly always because there is a space occupying mass in this area, which is usually a bursa, but may be another cause of soft tissue mass, such as a ganglion, and that's the cause of the toes to splay. Ultimately, the joint capsule may tear on that side, leading to further deviation of the toe and often the crossover toe deformity like so. Finally, we need to consider potential causes of pain within the toes themselves. We've already touched upon toe deformities such as hammer toes, mallet toe, claw toe, and also crossover toe. Pain may be associated at the deviated interphalangeal joint with associated soft tissue irritation, corn and callus formation. The nails are obviously a common cause of pathology, so it's important to assess the nails for normal morphology to ensure they're not ingrown, dystrophic, etc. A subungual exostosis or osteochondroma is a bony outgrowth which can occur underneath the nail. It classically affects the hallux, but can affect any of the lesser toes. It usually causes distortion of the nail and is associated with pain directly palpable on the osteochondroma. A much rarer cause of pain underneath the nail or on the apex of the toe is something called a glomus tumour. This causes exquisite pain and is often difficult to differentiate, but the clinical history of unbelievable pain is the main diagnostic feature. If patients complain of multiple joint pains in the ball of the foot, the toes and the metatarsophalangeal joints, one must consider the possibility of an inflammatory arthropathy as the main cause. The obvious and most common cause for that would be rheumatoid arthritis, but all of the inflammatory arthropathies, ankylosing spondylitis, Reiter's disease, psoriatic arthritis, will cause joint problems either at the metatarsophalangeal joints or the interphalangeal joints, or sometimes both. Gout classically affects the first metatarsophalangeal joint in 50 to 75% of cases, and this must be borne in mind when you are assessing somebody with a painful first metatarsophalangeal joint.